Hey, thanks for joining us in Moving Conversations. Before we get on with the show, listen, I want to remind you that I'm going to be in Scottsdale, Arizona on April 12th and 13th with my post-rehab summit. So if you're at all interested in learning more about post-rehabilitation, low back pain, knee pain, hip pain, shoulder pain, all that kind of stuff, how to manage clients with those type of conditions, that's really the best place to find some great practical application on all of that. So Post-Rehab Summit, if you go to the website, thefirmbodypilates.com and hit the tab in the upper right-hand corner that says Post-Rehab Summit, that's where all the information is. Check it out, and I hope to see you all there. And now, on to the show. Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Hello, Nora. You look to be in a new location today. I'm not seeing our normal background for you. Where are you at?
I am in Los Angeles, near Studio City, and I am getting ready to teach advanced movement principles, the lower body at core conditioning. So I'm down here in rainy LA. It apparently hasn't rained in forever, and they're trying to put out the fires, and we'll see how all this goes.
Oh, interesting. Yeah, I think I've been to LA so many times, and I don't think I've ever seen a drop of rain. So that's very, I've heard it rains. I've heard rumors and myth of rain, but I've never experienced it.
Yeah, no, it's soggy today. Everything's running and dripping, and all the roads are slick. And yeah, it's happening for sure. Which is, I think, a good thing at the moment.
Very cool. Very good. Yeah, I'm sure they could use it. Well, today I thought we've been talking a little bit about the abductors and adductors, so it's kind of hip oriented. So I thought, you know what? Something that we haven't covered in tremendous detail would be labral issues, whether it be of the shoulder or of the hip. So I thought that would be an interesting topic to go over today because a number of us have dealt with clients with labral tears. So I figured that would be an interesting topic. Before we get on to that, though, do us a favor, hit the like and subscribe button on the platform of your choice. However you download us and listen to us each week, that's the way to do it. Hit the subscribe button. It will be in your feed right away. Ta-da! We're here Tuesday morning. As soon as you wake up, we should be in your feed. You can always reach us at movingconvos@gmail.com or Moving Convos on Instagram, Moving Conversations on Facebook. Those are the easiest way to get in touch with us. And with that pushed aside, now let us jump into labral tears.
I wanted to start this conversation with a bit of history. And I'm old enough that I have a certain history here, as is Brian. And one of the things that I wanted to bring up is when I first started practicing at St. Francis in 1989, labrum tears were not really a diagnosis. And what I want to say about that is MRIs were still really being figured out at that point. You know, yes, MRIs were being done, but I think they were still trying to understand what the imaging meant. There was a lot of trying to correlate what they were seeing on the MRI images with what they were actually finding in terms of pathology, et cetera, when they did an arthroscopy or they did a surgery. And labrums were part of that. So even recognizing that a labrum tear existed, I think took a while to correlate that with the MRIs and then for it to become I wouldn't say a common diagnosis, but become a diagnosis, both in the shoulder and in the hip.
And something else to think about with MRIs is they've gotten better. So the pictures, I mean, think of our silly phones here. When they first put a camera on a phone, it was like half a megapixel. You could barely see what the heck it was unless it was a close-up of something. And now it's better than a lot of, these high-end cameras were 15 years ago. So the MRIs themselves have gotten a whole lot better. And there's so many other types of imaging that can be done today. So you're right. Up until about 15 years ago, I don't really remember getting many, if at all, labral tears, or if it was, it was usually discovered during some kind of surgery and said, oh yeah, and there was a labral tear.
Right.
And they cleaned it up. but it
Right.
wasn't a diagnosis beforehand coming in as, oh, you have the reason your shoulder, your hip hurts is because of that labral tear. And that's what we really need to focus on. And that's what we need to fix. I didn't have that until about 15 years ago.
Right. And the other thing too, my sister, not my sister-in-law, my niece-in-law, there we go. My niece-in-law is a radiologist, she's an interventional radiologist. And we've talked about this and just talked about how the amount of data that gets accumulated over watching 8 bazillion images over a long period of time by a lot of people really refines
Yeah,
people's understanding of what they're seeing. In both normal and pathological situations, they just get a lot more refined.
sure.
So that's part of that. So Brian, let's talk about what the labrum is. I think you have some
Yes,
visual aids, if I
I
remember
do.
correctly.
I'm going to widen this out a little bit so I can show this. So let's talk about the shoulder first, because I find that the shoulder is very common. And I'm going to say this. Okay, this is conjecture. This is on my part, but it's something that I find with pretty much all the joints in the body. The more we use our joints, the more wear and tear we're going to have on our joints. Okay, so that just makes sort of sense. I can't tell you the number of people after they've had shoulder surgery or hip surgery where they've said, oh, yeah, and there was a labral tear. So it's not uncommon for the average person to have some sort of wear and tear in the labrum. Now, here's our little scapula. I'm going to do the shoulder first. Here's our scapula, and there's that glenoid fossa, or excuse me, the glenohumeral joint, glenoid fossa. And this bone, the humerus, is going to sit in there. And unlike a traditional sort of ball and socket joint, I always refer to this as more of the cup and saucer because it's not really, it fits in there, but it's not held snug like it is in the hip, And what the labrum does, it actually helps to deepen the socket a little bit. It's a little added piece of cartilaginous material that actually helps to hold and suck that in and give it a little bit more stability of the joint. So we're able to move better and move, more freely and with better efficiency.
So you can kind of think about it as like, again, since not all of you are watching on YouTube, I want to be a little more graphic in terms of our verbal description. If you
Yes,
think about a
yes.
plate, right? You think about a flat plate, and you think about putting an apple or a round fruit, an orange on a flat plate. If you tip that plate, that orange is going to roll to one side and fall off. The labrum is like putting a lip around that plate.
Mm-hmm.
And that's a little bit of a funny thing, but right. So if you just have a little bit of a lip on that then when that orange comes, it'll still roll, but it's going to hit the edge and isn't going to roll off. So what the labrum is again, this cartilaginous buildup, like a little wall that goes right around the glenoid fossa. So it just deepens that glenoid fossa, which if you've ever looked at those, is not particularly deep. It's got a little tiny
No, it's
indent in
very
it.
shallow.
Yeah. And that's where it helps to create some integrity and some congruency with that humeral head.
Yeah. And the hip is very similar thing. Go ahead, please.
So the labrum in the hip is very similar. It's just a cartilaginous ridge, if you will, that goes along the edge of the acetabulum. So when that femur goes into that acetabulum, that little cartilaginous, somewhat flexible rim, right, helps to suck it in and create a little bit of that vacuum feeling that we kind of want to have in our hips.
And the difference between the two primarily is in the hip, we also have the ligament structures that actually hold that together. So the ligaments actually help a lot with the labrum there in holding that together, where we don't have the same characteristic in our shoulder joint.
Right. The shoulder is just so mobile, right? That there's ligaments in the shoulder that keep you from going too far, but too far is really a long way, right? You think of the arm going all the way back behind you, like I'm reaching into the back seat of my car, and then coming all the way across the front of my body
and
to
all
reach,
the way overhead.
yeah, all the way overhead and all the way back. Like that's just so much mobility there. And yeah, there's ligaments that keep you from going past those ranges, but they're not creating a lot of inherent stability because they just need to be so long.
Yep. We need that. We need that for the mobility of the shoulder. Whereas in the hip, that's not what it was designed to do, was to have those ranges of motion, unless you train for that, like some dancers and whatnot. The average person is never going to be able to do those things with their hip. There's no way.
Right. It's not designed for that.
No.
So when labrums get injured, it is commonly from repeated excessive range of motion, often with force. So
Mm-hmm.
thinking about like dancer labrum tears are very, very common in dancers because they're extending and flexing that hip in extreme ranges of motion, often ballistically, repeatedly, or soccer players, right? Kicking the ball,
Mm-hmm.
kicking the ball, kicking the ball. Um, in terms of the shoulders, you think about pitchers or tennis players or
Big
swimmers.
time.
Same idea. It's repetitive force on that whole joint, and really on that connection between either the glenohumeral joint or the hip joint. That's really going to, over time, potentially create some wear and tear of that labrum.
And if you think about it, repetitive use is usually what's going to cause injury for a lot of things, including things like tendonitis and whatnot. This is
Yeah.
just another type of repetitive use injury, but this is more to our cartilage, basically,
Right.
of those joints. And when we have that sort of injury, where we're going to feel it the most often, is upon compressing the tear or
Mm.
pulling it apart. Those are the two that we usually will feel. So let's say the most common in the shoulder is usually in the anterior, is what I've seen, a lot of anterior and superior. So if I were to bring my arm across my body like a golfer would over and over and over again, I'd be compressing that joint. And that joint would eventually get ticked off because of all the compression. Much like if I went into some chest stretch and took that arm behind my body a ton, I'd be
Right.
pulling that open. And by pulling that open, you're basically causing additional tearing, basically not tearing, but you're pulling it to its limits. And again, the tissue doesn't like that. So those are usually when we're going to feel it the most, is upon compression or upon full stretch where it's pulling apart.
Right. So end ranges of motion is where it's most
Yep.
bothersome. And getting back to our principles, because this is how we think about it when we're starting to work with clients with a labrum tear, is one of the things that keeps that damage from happening is in joint integrity and joint
Yeah.
stability. Right. It's really when, if you think about the glenohumeral joint, it's when that humerus is sliding around and slopping around the edges that you're going to get more wear and tear. And same thing in the hip. If the hip's really nice and solid, that acetabulum, and moving in the ranges that it's comfortable with, it's not
Yep.
going to get the same kind of wear and tear as if it's a little loose or a little less contained, a little less supported. That's when you're going to get into trouble. So,
Mm-hmm.
mobility or lack of stability is oftentimes an underlying factor as well.
Yeah. Yeah. I've seen a number of people, especially baseball pitchers,
Yeah.
who have this. And usually it's following sometimes a rotator cuff issue. So they already have a little bit of lack of stability because a rotator cuff for some reason isn't doing its job as well as it should. And they're stretching it out to extreme ranges of motion. They're doing a ton of external rotation and they're coming across the body into internal rotation in a ballistic fashion. And eventually the tissues just have too many repetitions and begin to have that breakdown. And again, it's creating greater instability within the joint. And I can tell you, being a former pitcher and working with pitchers, that is one of the scariest things. Is you don't feel necessarily pain all the time, but you can't control your pitch. You can't control your throw as much. Your body
Oh.
isn't doing what you're telling it to do. You feel unstable.
Like your aim is off,
Yeah, like something's
right?
just
Because you
not
can't count
right.
on it all organizing the way it should.
Right. And again, I didn't pitch at a high level, so I can only imagine what someone who does pitch at a much higher level that has pinpoint accuracy, suddenly things are not where it should be, and their shoulders feeling very wonky and very unstable. And that's when, they know something's going off.
Yeah. Yeah. So one of the things when I was doing a lot of the research for the advanced movement principles, I was looking up what do they say about how to treat labrum tears, basically. And for
Mm-hmm.
both hip and shoulder, unlike some other injuries, it was like you want to take a conservative approach first,
Yep.
meaning you want to do the best you possibly can in terms of strengthening, in terms of regaining proper joint mechanics, in terms
Yep.
of balancing mobility. Like that is the first step always. Surgery is really, I wouldn't quite say a last resort, but it is not a first resort.
Mm-mm.
Sometimes with meniscus tears, they're a little more like, yeah, we'll do a meniscus tear. Like, we'll just repair it. It'll be fine. But they don't do that with labrum tears. At least that wasn't the impression I got from everything I read. It's like, no, we really want to see how much we can do. Again, with movement, with strength, with flexibility, with regaining joint mechanics first, and see how that goes. Give it that a substantial time to work, like they usually suggest 3 months ish or so, to really see if you can get things better that way before you even
Mm-hmm.
consider surgery.
I've always come from the conservative point of view. For me, exercise can handle or can help with a lot of issues like this. But I will say this, in the last 5 years or so, and maybe it's the area that I live in, it seems that surgeons are a little bit more prone to
Yeah.
wanting to just go in there and put a couple sutures in. Now, remember, this is cartilaginous material. It's not something that's going to heal. So literally, they're going to go in and put a couple of sutures in to take up that space. And from everything that I've seen, it's not nearly as successful a surgery as something like a meniscal tear or a different type of, surgery. And when I've had clients come to me and say, oh yeah, the surgeon's talking about going in and doing a labral repair, that immediately is sort of my red flag is, okay, I totally understand. And I, respect the surgeon. Let's take a conservative approach and maybe see if exercise can help first before someone cuts into you and does, something that's a little bit more permanent.
And Brent and I are not medical professionals. Let's just be really
No,
clear on that right up front.
absolutely.
So yes, obviously you're going to talk to your doctor and talk to your PT. This is really just based on our experience as movement
Mm-hmm.
professionals with the clients that we've had labral tears and what their outcomes have been. So I
Yes.
really want to throw that out there. This is not everybody's experience. It's
No.
just kind of been our thing. And I would say that the reason that more labrum repairs are being done is because, again, if you look at just the history of it, they're now better able to diagnose it. I'm assuming that surgical techniques are continuing to improve also, right,
Sure.
along with that, because when a diagnosis is new and they go in to find a mechanical repair, essentially, I think it takes them a while to figure out the best results or the best way to do that. But still, if you've got a client who has that diagnosis, see if you can talk them into or encourage them. And again, if they're willing. One
Mm-hmm.
other thing I want to say about clients is not every client is willing to do the work necessary to make the
Yes.
changes without surgery. I've
Yes.
certainly seen that in terms of ACL repairs, in terms of meniscus stuff. Like a lot of times you can manage those with exercise. And some
Mm-hmm.
clients are willing to do the work. Other ones are like, I'm not going to do the work. Then maybe
Sure.
surgery is a better option. I always got to make that call in terms of the client's ability and to actually do what's required, because it does take some work for sure, and especially with labrum tears.
Mm-hmm.
I've really found that when a client has one, and I've worked a little more with the hips and with the shoulders, but with both, it takes some effort. It takes some real time to get those mechanics working better. One
Mm-hmm.
example I'll use is I had a dancer, which is pretty typical in my world, who had an anterior labral tear, had a labral tear that particularly was painful in hip flexion. So like when I bring the leg up in front of them, or in hip extension. So typical.
Yep.
And one of the things was, and this is not an uncommon postural pattern in dancers, is they stood with a real posterior tilt. And I think of this, and this is a little bit of an image, so take it that way, as shoving that femur forward every time they were standing. So it's like they would basically like squeeze their butt, push their bottom of their pelvis forward. That femur, my feeling is that that would put pressure on that anterior part of the joint capsule and the labrum.
Makes sense.
Yeah, and so for her, it's like the challenge there was she had to actually learn to hold her pelvis differently, to have it be more neutral, so that femur was not being shoved forward to that labrum all the time.
Yep.
And this was a professional dancer. She'd been doing this for her whole life, basically. And it's like, for her, the idea of changing her posture was really a challenge, mentally more than physically. I mean, she had the ability to hold herself any way she wanted to, but it was like, oh no, this is how I do a plie. This is how I lift my leg. I do it from this position. And it was interesting to work through more the psychological barrier to making the change she needed to make to get those hip mechanics actually less stressful on the hip joint. So
Yeah.
that was an interesting way to have to work with that. And we did, and it really helped, and she got better over time. But whoo, those first 3 weeks were like, I hate this. I don't want to do it this way. This isn't what
Yep.
I'm used to.
I can only imagine working with a dancer who their default position has been ingrained in them
Yeah.
for 20, 30 or whatever it's been, that to really reorganize that in their brain has got to be a huge challenge, a
With
huge
any
challenge.
athlete. With
Any
any
athlete.
athlete. I mean, because they rely on that, like whatever the posture is, they rely on that. I mean, think about a friend of mine who worked with Olympic swimmers, and
Mhm.
one of them, their coach decided that their backstroke was not appropriate and tried to correct their stroke, and they lost seconds off their time.
Yeah.
And the coach had to just shut up and say, okay, well, whatever you're doing, it's working. I don't want to mess with this.
Yep.
Even though it's not proper mechanics from his perspective,
Yeah.
so
I
that's
had a
always something that's tricky.
I had a gentleman who developed a labral tear, believe it or not, from yoga.
Yeah, I can see that.
And for him, he went from doing nothing. He was doing absolutely zero. Former like
Mm.
basketball player, high schoolish, but really not athletic whatsoever in that sense. And decided I need to increase my flexibility.
Mm.
So how he did it, and once he showed it to me, it was so obvious. It was trying to do as wide a stance as possible and then hinging forward from the hips. So his feet were super wide, standing there super wide, and he was flexing forward from his hips and really forcing his legs and his femurs to go wider and wider and wider
Mm.
every single time, because he thought wider the better. It's better flexibility. And as soon as he showed me, I said, "Yeah, you're stopping that now. You're not going to do that anymore."
Right.
I basically showed him on the pelvis model here. I said, "This is where it shows you have the tear. Now, what you're doing is taking that femur and driving it into the tear every time, and then you're grinding it by hinging forward." And
Right.
his eyes got huge, and he went, "Oh my gosh, you're right." Like, okay, so instead of working on mobility of the hip, let's stabilize it first. Let's focus on the opposite and really getting it stable. Because he actually had scheduled, believe it or not, his doctor said his labral tear, he said, I don't know if we're going to be able to repair it. We may have to do a hip replacement. The guy's 41.
Mm. Yaza.
And I thought, okay, do me a favor. And I say this with a lot of my clients. Again, like you said, we're not medical professionals here, but I believe in a second and third opinion, big time.
Yeah.
Because I just had a client who, I'm going to say this, tore her ACL, and she has seen countless doctors. I've never seen somebody take this so seriously, has seen countless doctors, and every single doctor had a different opinion. And now she sort of has analysis paralysis. She can't figure out what she wants to do because she has too much information. But if you only go to one doctor and only take that one opinion, you may not see the big picture. So I suggested going to see another doctor who wanted the conservative approach and said, no, let's work on stabilizing it. Let's try and strengthen it before we do something more permanent like surgery. And it does help if you can get them, like you said, to be diligent about the work. That's huge. They've got to want this.
It's also, I mean, what I also say to clients is, even if we just put off the surgery for 3 months, like we give this a shot and you don't get where you want to go, prehab before surgery is a real benefit.
Huge.
From
Oh my
and
gosh.
occasionally I'll read something that says it doesn't have any benefit, but most, like my experience with clients who do the work ahead of time and then have
Yep.
any kind of surgery, whether it's a shoulder or a hip or a knee or whatever, their outcomes are just so much better. It's like the muscle
Yeah.
tone is already there, the movement patterns are already there, and they reestablish much more quickly after surgery. If somebody
Yep.
goes into surgery very deconditioned with poor movement patterns, they come out the same way. Only
Yep.
now they're more deconditioned and their movement patterns are weird.
Yep.
And they've got to relearn all of that. So
I think I told you
yeah.
I've got a bilateral ACL client. She tore both ACLs on a skiing accident. And for her right now, that's all we're doing is prehab, because she
Yeah.
has to have surgery on one because it's a lot worse than the other. She has it scheduled, and she's seeing me as well as a physical therapist, and she is working her quads like you wouldn't believe. She's an athletic mindset. And she said, man, My doctor basically said, you're going to do straight leg raises until you want to throw up. You're just going to keep strengthening this. And I love the fact that the doctor was on board with prehab because, like you said, how many doctors have said, oh, it doesn't matter.
Right.
But
we can
if I have to, if I have to wait 6 weeks or 8 weeks to get surgery and I do absolutely nothing and I don't recruit that muscle and I just let it go dormant, I'm going to be fighting so much harder afterward. Whereas for this client, her vastus medialis and vastus medialis oblique is firing like crazy. She's able to do a lot more than even she thought. It's unstable, but we're keeping her within her pain-free range of motion. And she's going to go in and recover so much better. And that's really the key. And it's the same with this. And I told my client, I said, you've got your surgery scheduled for 6 weeks. Okay, give me 6 weeks. And let me know as we get closer to the date. If you want to have the hip replacement at 41, I'm going to support you and I'll be here when you're done. But give me the 6 weeks. Let's see if we can actually strengthen it. And 4 weeks later, he said, the pain's almost gone. So again, that was his situation. Every situation is different. But he decided not to have the surgery. And that was 5 or 7 years ago. Oh, more than that. It was at least 7 years ago, 7 to 10 years ago. And hasn't had hip pain since.
Great.
So,
Great.
I mean, but again, it's in the back of my mind with every session that we work.
Yeah.
Okay, we're still going to focus on this because I want to stabilize it.
Yeah.
But as long as you keep them within their pain-free range of motion.
Yep.
Happy and healthy. And he hasn't thought about it since.
So that's your first job as a movement professional, is if you have somebody who thinks they have a labral tear or says they have a labral tear, and maybe they're looking at surgery, but again, surgeries are typically scheduled far into the future, depending on the circumstance. So again, stability, getting the joint mechanics better, limiting range of motion and pain-free range of motion are going to be your go-tos. I also want to talk about what happens after surgery, because I've had a number of clients, and this is where Brian and I've had similar experiences, and I'm just going to speak to our experiences because that is just a few data points on a large spectrum. But I've had a number of clients who've had labrum repairs in the hip specifically. I think you've worked more with shoulders than I have. And all I can say is the pain is different when they're done. It's not always necessarily better when they're done. So that's been interesting to me with several clients that I've worked with. It's like, okay, well, that pain is now gone, but there seems to be other challenges. And sometimes I think it's just how scar tissue develops after the incision and everything else in that area. I'm not even sure what all else causes the trouble. Maybe it's just the fact that the labrum has little stitches in it and is no longer like smooth. Like, I'm not really sure exactly what the challenge is. Sometimes too, just in terms of the surgery, they'll stitch it back together if they can. If it's really ratty and kind of destroyed and ribbly, they'll just have to cut out pieces of it, right? Like Brian uses this great example of sometimes it's torn, so it looks like mops, like mop hairs. Those are not going to go together well with sutures. So sometimes they just have to cut out part of the labrum, and that seems to cause its own challenges. Plus, the labrum is inside the joint capsule.
That's the big thing.
And I think that may be the biggest issue, that to address the labrum, you have to go somehow around through between the joint capsule. And if you disrupt the joint capsule, then you do get scarring in an area that is really needs to have some mobility, needs to have very specific ranges of motion. And if you've got scar tissue starting to glue up that whole structure, I think that's where a lot of the trouble comes post-surgically. At least that's my supposition when I look at that and I think about what changes with clients after surgery.
Anytime you have surgery, and I'm just going to put this as a blanket surgery issue, okay? You are affecting change to your original structure, okay? In one way, shape, or form. They're cutting into you. They're changing something. A teacher that I had once told me this, and I'm going to repeat it here. And he said, if I were to get one of those football players from the Washington Redskins to come and bust down this door that took it off the frame, everything comes down. I don't care how good of a carpenter you have come in and refix that. It's never going to be as good as it was when the when it was brand new, the first time it was put in.
Mm.
You only have original parts once.
Yeah, it's an analogy. It's a good analogy.
Yeah. So if they go in shoulder, knee, anything, they are affecting a change. Now, because they're scar tissue, you don't know what they're doing to joint capsule. You have no idea how they're going in. Are they going in between the ligament structures? Are they going in through one of the ligament structures and they have to suture that? How does it affect? Are they overstretching it so they have access to it? So now something may have been, there's so many variables that happen in any surgery, and it all depends on the surgeon and their technique. So again, you have one shot to have all original parts. So when a client is ready to jump on the surgery bandwagon, it's like, okay, cool your jets. Unless you're in dire pain, maybe let's talk to a couple of other professionals and just see what other options are out there. And if surgery is the best option, fantastic. I'm here for you. I'll support you 100%. But if there are conservative measures, maybe investigate those for a couple of weeks, month, 3 months, and then you can always have the surgery down the road. It's not like the surgeon's not going to be there and ready to take your appointment. They're still going to be there. So postponing it a small amount of time does mean you may be in pain a little bit longer. But as you just said, pain is going to be there after the surgery too. It'll be different. It's not going to be the same type of pain. And I remind people of that too. I have a client who's thinking about going in for a surgery, and I say, just remember, that pain may be gone, but you're going to have the trauma of the surgery you're still going to have to recover from, so there will still be pain. So just keep that as an overarching thought that there will still be discomfort afterward. And no matter what surgery it is, you're probably going to be 6 months to 12 months before you're 100%. 100%. You'll regain a lot in a short period of time. You'll get stronger, but 100% takes time and a lot of work.
And the fantasy of returning to some prior state, like is often a fantasy, so, and clients are, well, I would say the whole medical profession is like, oh yeah, you'll be fine. Right. There's definitely this assumption. Oh yeah, you'll be driving in 3 weeks, whatever it is. And from their perspective, they've done a good job. You don't have any infection. Everything is healing up appropriately. Great. Their job is done. But your job in terms of the client,
it's just beginning.
Patient, is just beginning, because you've got to get your body used to that new thing. You've got to regain whatever strength was lost. Maybe you were pretty much discombobulated for a month or so after the surgery, between being in the surgery and then not being able to move very much and whatever. And so then you've got to regain all that. And remember, probably said this before. If I haven't, I'm saying it again. On average, it takes 3 times whatever it took. Like if you were disabled or you were like lying in bed for a week, it will take you potentially a minimum of 3 weeks to get back to your previous fitness level, just from being immobile for 3 weeks. So if you think about a surgery where there's that plus all the trauma, it just takes time. And again, many surgeons do not let you think that there's that time. They really want to say, yeah, you'll be fine. And most clients are disappointed by that. So I just try to say, hey, your doctor's going to tell you this. He's going to tell you you'll be fine in 3 weeks. My experience has been, really just in your brain, think more like 3 months. Just put 3 months in your brain of, I'm going to work for 3 months, and then, I'll see some difference after that. Because if you really set expectations appropriately, you're a lot more successful, I think, in the post-surgical phase with any of your clients, or with yourself for that matter.
Yes. And I will say this, I'm often the voice of reason with these clients. I'm sure you're the same.
Yep.
Whereas the doctor will say, oh, you'll be in, therapy, 12 weeks, you'll be fine. And I'm usually the one that says, okay, 12 weeks, you'll be at 80%. That's fine. 6 months, you'll be at 90%. And they usually go, really? And you can see it in their eyes. And I say, think a year before 100. And if we make it sooner, fantastic. Awesome. Way to go us. Yay, team. However, put it in the back of your mind that it might be upwards of a year. I remember when I had shoulder surgery a few years ago during the pandemic, the doctor and I were talking, and he said, now, I got to know him. He was sort of a friend. And he said, now I want you to think about, it's going to take a little while for it to heal. I said, oh, I'm a year out before I'm 100%. He looked at me and he said, wow, Yeah. And I said, I'm 12. And I said, yeah, I
My
know,
goodness.
12 weeks, 12 weeks,
Uh-huh.
I'll be at 80%. He said, exactly.
Mhm.
And you can see his eyes were like, okay. And I said, it takes time. It takes time for me to build back because I've been dealing with this nagging injury for years. So guess what? It's going to take some time. So by us putting that into the client's head, I even had a client this morning who is going to have to go into surgery. I talked with her and I said, look, or she asked me specifically, she goes, where will I be in, a month after surgery? When will I be off the crutches? When will I be, and I said, okay, I know your personality. You're probably not going to use the crutches beyond a week. However, the doctor's going to tell you they want 6 weeks, maybe 4. But I know you and your personality. You're going to walk into the doctor's office and at the door, you're going to grab your crutches and start using them. I know you because I'm similar to that. But she wanted to know the truth. And I said,
Yeah.
here's what it's going to be. And putting that realistic expectation into their mindset is huge because then
Yeah.
they're not surprised and they know, okay, they can sort of hunker down that I'm ready. I can do this.
They can also make plans because very often people are
Yeah.
saying, oh well, I have a big trip planned for, I'm going to Italy for 3 weeks and I'm going to be hiking the Cinque Terre or whatever in July. And you're like, okay, well, if you're having surgery
Maybe.
in May, you may need to change those plans, right? Whereas if you're
Yep.
having surgery the previous October, yeah, you'll probably be ready to do something like
Yep.
that, or at least, we'll do the best we can, and maybe you have to modify a bit, but you'll be able to manage it.
Right.
So it's also just allowing people to just think rationally, which nobody ever wants to in these circumstances, about their future.
Sure.
So yeah, and with labrum tears, I am like it's like with it's like with knee replacements. I'm the same way. Like this is going to be a while. Or ACL repairs. Those are all ones I'm like, well, be patient. You know,
Yes.
meniscus tears,
Yes.
like yeah, usually you will be pretty good, pretty
You'll
quick.
walk,
It'll,
you'll walk out.
yeah, you'll be pretty good. Shoulder stuff always takes longer than they say, is in my experience.
Yep.
So just trying to help people understand what's required and that they'll have to do stuff. Which if
Yeah.
they're seeing you already, they know that. The challenge
Yeah.
really, and I have great sympathy for physical therapists, really great sympathy for physical therapists because I've seen several in systems like Kaiser who have a client who has done nothing,
Yep.
who has surgery, and who shows up and is given 6 sessions to get post labrum repair of their shoulder back functioning. I'm like,
Yeah.
that's
Not
just
happening.
yeah,
Not in 6
it's not going
visits.
to happen. It's just not going to happen. So,
No.
there's a no-win situation there, both for the practitioner and for the patient.
Yeah.
And that's,
Yeah.
our glory, or one of the beautiful things about what we get to do is we have clients who've been seeing us forever, who
Mhm.
know what it takes to be physically active and we're willing to do the work. And that's what makes the difference and really helps our clients to make huge progress.
Yeah. Yeah.
Yeah.
And I think with labral tears in general, the thing that we need to focus in on, whether it's pre-surgery, post-surgery, anything, is all about creating the stability of the joint. It's all about trying to get that stability back in the joint. And for my clients that we do prehab or hopefully not have to have surgery, strengthening the heck out of it and trying to get
Yeah.
good range of motion. And again, remember what hurts and ranges of motion. So staying in between the areas that don't hurt, that pain-free range of motion, working that and really trying to create stability and better mobility in those ranges of motion so you can really see that the joint is moving the way it's designed to, really seems to help a lot.
Yeah, that's the critical thing. And we've talked about that in the last couple of episodes about abduction
Yeah.
and adduction and how the femur should be moving in the socket. And it's the same thing in terms of working with the shoulder or the hip. It's like, getting scapular mobility to work rather than glenohumeral joint to work, right? So getting upward and downward rotation of the scapula moving,
Mm-hmm.
getting the rotator cuff to have integrity. So when you're
Yes.
rotating that glenohumeral joint, you're not rolling that humeral head back and forth in the socket, but instead you're keeping it really centered, creating congruency in the joint. All the things that we work on like mad in terms of just basic training and basic good physical mechanics is critical for somebody who's got a labrum tear or a joint issue of any kind. Stability and
Yep.
then strengthening strengthening, strengthening, strengthening,
Yeah.
strengthening in proper mechanics and with good range
Improper
of motion.
mechanics.
Yeah.
And again, when you look at it, let's look at proper ranges of motion. If you know you have a tear in the anterior compartment of either joint capsule, you may want to avoid going into that. So you want to train just around it. So
Exactly.
you can find the ranges of motion that seem to help, that
Yep.
don't seem to hurt nearly as much. And that's really where I will try and be, especially for the shoulder joint. Doing a traditional sort of bench press with my elbows out wide from my body in abduction
Yeah.
will often compress that. However, I can do a press with my elbows into my ribs and go into more shoulder flexion, staying in the sagittal plane rather than in doing more of a horizontal abduction, and it seems to help. And maybe that hurts. So take it out 10 degrees further, 10 degrees. By slowly finding that range of motion that doesn't bother it, you'll be surprised that it'll be like, oh yeah, this doesn't hurt at all. Guess what? That's your magic motion. Let's focus on that for a little while and see if we can bridge that area a little bit and create that strength and that stability.
And Brian uses the analogy a lot, which I like, which is, again, stay within that narrow range and then just very gently push in the two directions, right? Gently push a little more, like if they're having trouble with flexion or, horizontal adduction in the shoulder, then, don't go into that a lot. Work more on the other ranges, of which there are plenty to work on. And then slowly start to see if you got a little more tolerance towards that troublesome spot. And over time, you'll typically gain that, because as everything gets more stable and stronger, you can often push it a little past where it was before.
And also, like anything else, if you have something that's inflamed and angry, every time you touch it, it's going to bother it.
Yeah.
But a year from now, if you haven't ticked it off, the inflammation should be reduced. And guess what? You're going to be able to reach across your body a couple of times without it hurting. It's not going to be as inflamed, provided you don't continue to do that range of motion over and over and over again, which I've seen some people who have had shoulder issues and they stop playing competitive tennis for a while. And it's great. Then they pick up something like pickleball because in their mind, it's different. Okay, maybe not really. And so things start getting a little bit grouchy again. And I have to remind them, okay, let's modify how you're hitting the ball. Let's change that. Or maybe that's not the sport for you.
Right. And that's the challenge. I mean, I've worked, again, as Brian, a lot of professional athletes, and it's kind of like, this is how they live their life, right? So using these ranges of motion, whether it's a dancer or a soccer player, whatever. And in those situations, it's a lot trickier to just try to give them things. And sometimes if I'm working with clients who are more on the occasional side, the amateur side, they're like, I like to do this every now and then. Sometimes it's allowing rest. So one of the things that, particularly as we age, rest is more important, is I've got to tell those clients, like, okay, so you can play 3 times a week. You can't play 4 times a week.
Yep.
Or for my dancers, like, you can take 3 ballet classes a week. You can't take 5.
Yeah.
And just give, because the body, oftentimes, if you give it a day or 2 of rest in between things, it will recover. If you don't, it won't recover. And that's when overuse things happen and irritation comes up and inflammation starts to get bothersome.
I get that with my people who have knee issues and that love to ski.
Yeah.
Well, they're going to go out to Breckenridge. They're going to go to these places that they're spending a ton of money and they want to get the most bang for their buck and they want to go out every single day. And I'll tell them, ski for 3 days, take a day off. They'll say, but I say, no, trust me, 5 or 6 days straight, the last 2 days, you're going to be miserable. Your knees are going to be hurting.
Exactly.
And it's going to take us 6 months to get your knees back to calm them down and to get them strong again. Whereas take the day in between, go do something else, and then ski for the next day or 2. Right. And you'll be surprised. Those who do that say, this was one of the best skiing vacations we've had in a long time. Whereas last year, they fought it the last 3 days and they didn't enjoy themselves. So by adding that little bit helps.
And skiing's classic, right? Because many people don't ski at all and then go and ski for 7 days straight.
Exactly.
And that's all they'll do in a year. They'll go their one ski vacation, and they'll pack it all in with no preconditioning or minimal preconditioning and whatever. So exactly, it's like, okay, so ski a half day the first day, ski half day the second day, maybe a little longer the third day, take the fourth day off, and whatever. Like
Yep.
just find some way to make it so they can keep doing what they're doing. Because again, rest is oftentimes what will allow that to keep happening and to keep the pain down.
Something else that popped into my head, and I'm going to mention it here. For those clients who do a sport, like a tennis player, golfer, or whatever, a lot of times those clients, they may be really gung-ho about it, and it's great. When I find they get injured is my golfers who spend much more time on the driving range instead of playing. So they're sort of grooving over and over and over. It's really repetitive. Or this is the classic one that I see all the time. My tennis player who's going to go to tennis camp for a week. And they're hitting the same shot, and they're taught how to swing, how to hit the ball differently, put spin on the ball or whatnot. They all come back with shoulder or elbow problems that can become a nightmare. And it's all because they're in their 40s, they're in their 50s, and they're doing hundreds of repetitions in a very short amount of time. Whereas if you're playing a game, you may do that same stroke 10 times in an hour, 15 times in an hour, because you're doing all these other, strokes.
Yeah. And you'll never do exactly the same way. It's not the same
and
thing
not
as
grooved at you over and over and over.
Or whatever, right?
Yeah.
Because the ball's coming a different angle. You're in a different place. Like you're moving that joint in a bunch of different angles. You're not doing like this same thing.
And that makes a huge difference. So I do warn clients, if they're planning to do that, it's like, okay, just be prepared that if you're asked to do something like that you're spending that much time doing. And I see this a lot with my golfers when they're trying to adjust their swing, or it's the winter and they're going to go to the driving range 5 days a week. Oh my gosh. Okay. I know what I'm going to see, because they're doing the same thing over and over and over again without the walking in between, without the resting between, grabbing different clubs, all the things that you would naturally have in a normal game, you no longer have. So just keep that in mind for those clients. Rest can be critical. And with the labrum, it's very critical to let it calm down. Whatever has bothered it, make sure you avoid that. Let it calm down.
Yeah.
Huge.
So what do you think, Brian? Have we covered labrums?
I think so. I think we've done pretty good. Again, for labrums, honestly, it's all about stability of the joint, staying within that pain-free range of motion. And do what you can. Do what you can. And believe it or not, what you're going to find is most of them, I'd say 95% of the ones I've worked with, they start feeling better in about 3 to 4 weeks time, just by stopping doing what's bothering it and by doing the right thing to stabilize the joint and work on proper movement mechanics. And believe it or not, things start calming down. And 6 weeks later, 8 weeks later, they're like, oh yeah, I don't really notice it as much. So give it a try. See if that helps for your clients. See if that works for you, if that's your issue. Yeah. Well, good. Good. I think we covered that pretty well. If you have any questions on this topic or any others, hit us up, man. movingconvos@gmail.com is always the best way to get in touch with us. You can also DM us through our Instagram at Moving Convos. Moving Conversations on Facebook is also the way. Do hit that like and subscribe button. Please comment, share, do all of those things. All of that really help us out for our algorithms. It helps spread what we're doing to more people out there. So we really appreciate every comment we get, every share we get, every like we get. We really appreciate it. So I think we covered it for today. For Nora St. John, I'm Brian Ritchie. We'll see you next time.
Bye, guys.